So welcome everyone. Thank you for joining our webinar, Co-Designing Care to Improve Black Maternal Health Outcomes. My name is Aisha Seda. I'm a Senior Program Manager at the American Hospital Association. This event today is in recognition of Black Maternal Health Week and National Minority Health Month. We hope that you will find this webinar beneficial, and we encourage you to participate via our chat or get on camera during our Q&A session. And please note that this webinar is recorded and the slides for this webinar will be shared with you post the call. I wanted to also share that the AHA is committed in helping our hospitals and health systems improve maternal health outcomes by sharing best practices that we're hearing from the field. Our website holds a number of resources, such as podcasts, case examples, web pages dedicated to maternal mental health and child and adolescent mental health. And then we also have our partners in the advocacy and policy department to help lead some maternal and child health policy efforts. As part of our efforts, we bring together healthcare leaders from the field to share best practices that they've adapted in their hospitals and health systems and communities. And then we'll be sharing that out with the field. So with that, I wanted to kind of just quickly talk about the state of maternal health in our nation. As many of you know, the maternal mortality rates in the United States have more than quadrupled since 1987. And women of color bear a heavier burden of maternal mortality than their white counterparts. When compared to white women, Black women are 3 to 4 times more likely to experience a pregnancy-related death. Black pregnant women are 60 times more likely to develop preeclampsia than white women. And then 60% of Indigenous women have an existing heart condition. All of these factors make it harder on their pregnancy and pregnancy outcomes. Also want to note that Black and Indigenous women have 2 to 3 times more likely chances of developing a maternal mental health condition. Again, another factor that makes it harder on their pregnancy journey. These disparities must be recognized and addressed at the forefront of maternal care. Hospitals and health systems alone can't do this by themselves. We need partners within the hospital and outside the hospital in the community. So to ensure that we are collectively and collaboratively improving Black maternal health outcomes, we must co-design solutions with our communities and with our patients' needs in mind, and really target their health concerns. These clinical community partnerships will be a pathway for better, equitable maternal health outcomes. So to discuss the importance of what co-design Black maternal health care looks like in alignment with community and patient needs and preferences, we bring together a panel of experts in this space. So first we have Dr. Kim Gregory, who is the Director of Maternal Orthopedic Medicine, Vice Chair of Women's Healthcare Quality and Performance Improvement in the Department of Obstetrics and Gynecology at Cedars-Sinai. We also have Tadra Anderson-Rhodes, who is the Chief Medical Officer and Perinatal Patient Safety Lead at Memorial Hospital Miramar, which is part of Memorial Health System. And we have Cheryl Johnson, who's the Clerkship Director in the Obstetrics and Gynecology Department at Akron City Hospital, which is part of Summa Health System. To moderate this panel, we have Joy Lewis, who's the Senior Vice President of Health Equity Strategies and the Executive Director of the Institute for Diversity and Health Equity at the American Hospital Association. With that, I'm going to stop sharing my slides. I'm going to turn it over to you, Joy, to start moderating the panel.
Awesome. Thank you. Can you hear me just fine? Okay, great. So thanks, Aisha. And I want to just add my own welcome to everyone and welcome to Black Maternal Health Week, which begins today through next Wednesday, the 17th. And thanks, Aisha, for setting the stage and for providing this venue, this opportunity for our participants during Black Maternal Health Week to give further thought to the actions. Much of the work that we are leading here at the AHA is around the development of actionable solutions. And we lean into the notion that we need to develop these solutions in partnership, co-designing with our community actors and our community partners and stakeholders. So I think we've moved past the raising awareness stage. We don't need another study or another set of data to tell us that we've got a vexing challenge in front of us that we really need to solve for this maternal health crisis that we find ourselves in as a country. And so today we really want to lean into this notion of clinic community partnerships, and I should say effective clinic community partnerships as one facilitator to advance equitable maternal health outcomes. So to kick things off, because you guys are here to not hear from me, but to hear from our experts in the field, I want to start by asking each of you to describe the state of Black maternal health in your respective communities. And specifically, if you can call out for our audience today, what are some of the more prominent challenges that you're seeing among Black pregnant or postpartum people in the communities you serve? And I'm going to start with you, Dr. Gregory, and then we'll hear from Dr. Anderson Rhodes and finally Dr. Johnson.
Good afternoon or morning, wherever you are. And thank you for having me. And I'll say that overwhelmingly, the two challenges that I'm seeing, the biggest challenge I'm seeing is fear and anxiety. Like I'm here doing an ultrasound, and the first thing that patients, I'm telling them that their baby's okay, and then they want to know, am I going to be okay? Am I going to die? And I'm like, oh my God, wait a minute. And we really, I think that it's really important to know that yes, maternal mortality is rising in the United States, and yes, there's a disparity between Black and white women, and yes, we need to do more about it. But if we think about in California, the maternal mortality rate is about 19 per 100,000 deliveries, and California does 400,000 deliveries per year. So that means that more than 390,000 plus women actually do just fine. And so we really need to remember that that God willing, the statistics are really on your side. And so I spend a lot of time just trying to reassure women that that they're likely going to be okay. And then the second challenge is everybody wants a Black doctor, and they're just not enough of us. A provider, because it could be a midwife, right?
It could be, yeah. So that concordance piece, yep, definitely a challenge.
Yeah.
Dr. Anderson Rhodes, you want to weigh in?
Yes, ma'am. Can you all hear me?
Yes.
Thank you. And again, I want to thank AHA as well as you for putting on this great forum, because it is a crucial conversation and a critical topic that we have to address, and we must address expediently. So I think here we're in Florida, South Florida more specifically, and we are seeing the same type of crisis that is being seen nationally with regards to Black maternal health. In fact, here in the state of Florida, and when you get to the more Black and brown communities, the statistics and the gaps in terms of healthcare disparity widen. And that's distressing, because already in the state of Florida, we know we are at higher risk if we are Black and brown for maternal mortality. We already know that. Our statistics, I think my colleague just quoted 19 in California, it's 26 point something here in Florida, above the countrywide average. So in Florida, we have a problem. And we've looked at that all the way down to our county level, as well as our own healthcare system, which is Memorial Healthcare System, where I am fortunate enough to lead the perinatal initiative for our system. And we are aligned, unfortunately. So whereas the country may say 80% are of our deaths might be preventable, we're seeing the same thing here locally. And in spite of the fact that we give outstanding care to our patients, we're part of that bucket, especially here in Broward County, that even the March of Dimes, our rating is a D. And so we have to acknowledge that we've had a problem. And we've done that at Memorial Healthcare System. So now our challenge is with these disparities, both in mortality and morbidity, and for our audience, the morbidity is any of the complications of pregnancy. Our number one that we're tackling, and we've seen over the years, is hypertension and hypertensive disorders in pregnancy, which then lend themselves to some of the outcomes that we're seeing. So that would, I'd say, would be number one. And our second is really to try to look at the preterm births. We haven't really made a dent, as you know, elegant as medicine is, and as fortunate as we are to be in this type of country, you know, where we do have a better equipment and supposedly better outcomes, we really don't see that. And so in the state of Florida, when we look at our infant deaths, the second leading cause of those deaths is preterm births. And so how we're going to tackle that, again, the state of Florida is at a D+ level from the March of Dimes, and that's the compilation of statistics from national healthcare databases that March of Dimes has compiled for us, and we just don't do that well. And so we have to try to address these challenges. Our rule number one for trying to do that, obviously, is listen and listen well to our patients, and trying to be really thoughtful about addressing the women's concerns, and not with just ourselves. So I love that this is a partnership that we're talking about, but how can we engage our community and our community partners to help us do this work? I think the Hear Her campaign is one of the best that I've seen, and we do hold the stories of our own patients in Memorial, similar to those of the renowned athletes like Allison Felix and Serena Williams. We hold those dear, and so we call their names because what we want to do is center our patients by name, center the health equity that they deserve to really drive the improvement with our partners.
Awesome. Thank you so much for that very thorough download of what you're observing there in your part of Florida. I want to invite Dr. Johnson into the conversation.
Sure.
Are you okay?
Yes.
If you're able to hop on camera, that would be great.
Oh, my camera is on.
Oh, we can't see you. Okay.
Huh.
But let's keep going.
Okay. Well, thank you for having me. Hopefully you'll see me shortly. So I appreciate being on the panel, and I also appreciate the intentionality in regards to the different areas of the country in which we come from. So I'm from Ohio. Like it was said in the introduction, I represent Akron City Hospital, Summa Health System. And so based on how we're doing in Summit County in regards to numbers, specifically infant mortality, we're looking at about 7.4 per thousand births. But when we look at Black infant mortality, we're at 11.5 per thousand births. And so as everyone eloquently pointed out, ever since this data has been looked at since 1935, this disparity exists between Black birthing mothers and our Caucasian counterparts. And so I know we'll get into that a little bit more. But in regards to the second part of your question, regarding challenges that I've seen in the community of Black pregnant birthing mothers, what I'll say is that overwhelmingly they report that they're not feeling heard and that they're not feeling seen. And so how this plays out clinically is that they're either not seeking care, so they choose not to receive prenatal care, or they engage in seeking care late. I also see that moms will discontinue services early because they do not like how we make them feel when they're in our presence. And then last, I see that they're either seeking care emergently.
Thanks so much, Dr. Johnson, for sharing what you're observing there in Ohio. So I'm hearing some fear, some anxiety, maybe some mistrust of what they can expect when they show up to our front doors to receive care, and certainly an acknowledgement that many of these disparities are in fact preventable. in nature if we provide and apply the right dosage of interventions, if you will. So as we started out at the very top of the hour, sharing that we recognize that we can't solve this crisis alone, right? These disparities are long-standing. They have a really long tail. And so because if we could have, we wouldn't be having this conversation here today. So can you describe for our audience what the importance is then of having hospitals and health systems partnering with their community-based organizations and again, co-designing the solutions, ensuring that the voice of that end user is a part of that solution set. So I'm going to do the reverse here and start with Dr. Johnson, and then we'll come to you, Dr. Gregory, and we'll wrap up with Dr. Anderson Rhodes.
Of course. So in regards to partnering with the community, I think that is the most important work that we can do and that I have been involved in doing over the past several years. And so I think the best way to answer this question is to talk a little bit about who our community partners are and what strengths they bring to the table so that we can show up for women in Northeast Ohio. And so our first community partner is Project Ujima. So they're a grassroots organization. So their whole goal is to make brothers and sisters' problems their problem and to solve them together. And so I think having a community partner like that is imperative because they have their hand on the pulse of the community. So they always make sure that they represent the voice of the community, that they're bringing forward what the concerns are, so that we're tailoring that into whatever treatment that we are providing. Our second community partner is Minority Behavioral Health Group. So they provide the maternal mental health component. So they are Black and Brown therapists that show up for patients that are Black and Brown. And so in conjunction, Summa, Project Ujima, Minority Behavioral Health, we have developed prenatal care and have rolled it out in a way that is African-centered, that always judges their progress and is empowered to paint as we go so that we can have moms advocate for themselves, seek whatever education it is that they are seeking, but also that their voice is heard in regards to the programming and what it is that we can bring to them. And I don't think that any of us three entities could do the work we've done in a silo, which is why these partnerships are imperative.
Great. I'm going to come back to you later for some outcomes and some learnings from those partnerships, but I want to pitch to Dr. Gregory.
Yeah, I think what community-based organizations do and the community does, and probably our biggest partner is doulas and birth advocates, is it teaches women the language, or what I call the buzzwords, right? People, even now, my family will call me up and they're saying that they're going to the doctor and, they think they have heartburn. I'm like, well, you're going to be in the ER a long time unless you say you have chest pain, right? So there are some buzzwords in obstetrics that will get you seen. And we need to make sure that people get seen. I'm not saying to lie, but I'm saying that if you're concerned, then you know your body and something's not right. And you shouldn't be dismissed. And there are ways to not be dismissed if you talk the language. And so I think that that's something that birth advocates and doulas can do. And I think the other thing that community-based organizations can do, which we as clinicians are not very good at, and that is to make people aware of wraparound services. That there are things that people know who are in the know, and you want to make sure that you get in that loop of information.
So you're already dipping your toe in the water of how do we expand the workforce, right? The definition of who's there as a part of the care team to include doulas and others who might be able to advocate on behalf of that birthing individual when they're at their most vulnerable point for many women. Um, so and I'll just tip my hand here. So I've been to Akron, Ohio. I gave birth at Cedars-Sinai. That's my, yep. So you hold a special place in my heart. And Florida, my dad lives in Florida. So I'll toss that to you.
So
Excellent.
you're well represented.
Well represented, well represented.
I love it.
Do you
I
want to
love
go,
it.
Dr. Anderson Rhodes?
Yes, I love it. And I want to say I wholeheartedly agree with everything that the my colleagues have shared. You know, one of the things that I'd like to point out in terms of why partnering with our community-based organizations is so important, and a wide variety of them, is because the reasons for the crisis we're in as a country, as well as our respective communities, are so varied and so broad. So you touched on mistrust. We also have, or, you know, lack of trust. We also have variations in care. Sometimes that's knowingly, but sometimes that's unknowingly, and our partners have to point that out to us. We also have the lack of insurance or underinsured per se. So we also need partners who can talk to the payers, who can talk to a variety of these issues. And then other barriers of care. So where are the barriers in our communities? And while we are the community per se, those who are actually out there who are maybe more trusted than we are, you know, these are lessons we learned during COVID. We knew it before, but COVID shone the light. We have to pay attention then to those lessons. And a lot of that was done through our community-based organizations, including our faith-based organizations, going to synagogues, churches, whatever types of places that the people are, where people are trusted, helps us to get the message and to get the education and to get the services across to them. So I would say for us, the importance of partnering is one of our number one objectives. We rarely do anything alone, and we have been able to find those types of really trusted community partners, such as March of Dimes. Our South Florida March of Dimes is in with us on so many different projects, but not just them, Healthy Mothers, Healthy Babies, which is intentional in marginalized communities specifically. So that's where they are. Mental health resources, as you've heard already. Healthy Start, I can't say enough about our Healthy Start partners, especially those here in the Broward Coalition. We're actually doing a baby shower tomorrow at our institution, but like people can come that they're going to get food services, they're going to get nutrition, they're going to get all these types of things. One is going to be held at one of their sites in the community, because right, sometimes it's not easy for the community to come to us, and our partners have to say, hey, you're making it really difficult for people to get to you, so we're going to them. But we're also going to do one in our building at our biggest campus, where they get to come in and choose things. We don't package it for them, they'll choose things. And sometimes our partners have to shine the light, again, whether we think so or not. We all have biases, right? We all have our preferences. So they open our eyes to some of the cultural stereotyping, that implicit bias that we need to be aware of, so that we're also, as good as we are, and we are really great, that we're culturally appropriate, and that we actually don't try to bring everything to us, but that we can also take those services where they're needed out in the community. One of the real beauties of our partnership with the Broward Healthy Start Coalition, they're doing implicit bias training. We don't have to recreate the wheel. They can help us, and we can garner what they are already experts in and who they've already have to do that, and make that available to our practitioners, to our young medical students, our young doctors, our residents, so that they get that culturally competent care aspect early on in their training to care for our most vulnerable patients. And we think that what that really does and sets us apart is it builds the trust that we really need between providers in the community, as well as us as the community provider. And so that's what we're trying to leverage, and we think that's going to move us forward even more than we could do so by ourselves.
I think that's right. I think that's spot on. And welcome, Dr. Johnson. We can see you now. This notion that it would be from our direction into the community is a miss, right? We absolutely need to recognize that communities know what their needs are. And I was at a roundtable last night, and they were talking about shifting the language from community capacity and community building to community enhancing, because the community already has its strengths. And how do we as hospitals partner with the community to amplify, again, what the community already knows about themselves? And then this notion of really the cultural sensitivity and humility that is required of our providers to better understand who is in front of them and the broader, larger context from which that individual comes. So that person in society world, kind of that view is really important, so that you're not singularly boxing any pregnant birthing person into this box and slapping a label on them and then reacting to and treating them in a certain way. So when you talk about these really strong partnerships that you're proud of, leveraging them as the messengers, right? Can you share a little bit more about some outcomes, some learnings that others might be able to take away? If there are any that are particularly focused on really tackling the disparities, the structures that we know can perpetuate harm, or that can lead to some unintended consequences, as you pointed out earlier. That would be really, I think, instructive for our audience. So what are some specific outcomes and learnings that you can call out? Dr. Johnson, do you want to start?
Sure, I can start. I spoke to our community partners, and I said that we had an African-centered approach. I think I neglected to say that the way that we provide prenatal care and postpartum care is in the centering format. So we follow the centering pregnancy model brought forth by the Centering Healthcare Institute. And so that's a proven model that has shown, and it has also shown with the women that we serve, to have a lower preterm labor, lower preterm delivery rate. But I think that what was most surprising is that we saw an increase in breastfeeding rates postpartum. And I know that a story that comes to mind, or how I can make this come to view for those of you listening, is that we circle up in community and all voices are equal. So even though I'm the OBGYN in the group, my voice is equal to every mother in the room. And so when moms deliver and they come back with their newborns in the circle and they're breastfeeding, I think that it speaks to the power of community. So it's stories like that, and it's interactions like that that break down some of the barriers that Black mothers have in regards to their views on breastfeeding, views that they have from their mom or their grandmother, or the ways that they should or could not do things. So when they actually see someone who was on this pregnancy journey with them doing it, they feel empowered. They feel like, if she can do it, I can do it. And I think that's why we see the higher breastfeeding rates. And so that's just one outcome that comes to mind, but it speaks to the power of bringing Black women together in community.
And having that shared experience. Very
That's right.
powerful example. Thank you. Dr. Anderson Rhodes.
Yes, I love that, by the way. We might be stealing some of
Amazing.
that or borrowing it. That's why we're here, right?
Exactly.
Learners have to be continued learners. You know, one of the initiatives that we have so many different programs, and I could be here like for a year talking about them, but we're really proud of work that we did. After we identified, again, our higher rate and the disparities in the hypertensive disorders, I think I mentioned earlier, we partnered with the Florida Perinatal Quality Collaborative, similar to one they had in California, looked at our data, how we were treating patients, did we have the right order sets, bundles, and things like that, made some adjustments, found that we were a little behind, and with our perinatal patient safety initiative and our restructured maternal fetal medicine program with a chief in-house that didn't negate what the work that was being done by our community providers, but brought it in-house, and we all decreased some variation there, we found a huge opportunity in identifying patients who had high blood pressure at any point in their pregnancy and what would happen to them when they left our building. And so we saw that as an opportunity, and one of our directors of nursing and family birthplace, Jessie, who was actually a midwife, and the team created these little teal bracelets, which may be a little hard to see in my teal background, but it says the word preeclampsia on it because that's the nomenclature we used back then. And when a patient is identified in our healthcare system at any point in their pregnancy or even postpartum, they get this bracelet. And what we did, we extended the program because we have lots of providers who are not intimately connected with us. And with boots on the ground, with our other community partners, they went to like EMS, they went to fire stations, they went to hospitals that didn't have OB programs. They even taught our own ED folks to say, if a woman, and we taught the patient, it became like an alert. So it would empower the woman like, hey, you need to pay attention to this. And so a huge outcome was the recognition of preeclampsia for those especially who were most at risk, who didn't really feel they had a good voice to say, no, that 140/90 is not normal. That's somebody, it's not normal in anybody, but it's definitely not normal in pregnant patients. And so fast forward post-COVID, we were actually able to partner with Essentials Hospitals, which is a national organization, get a grant and address them, those who are most vulnerable, who now we've identified them. What can we do further? So they could be 6 weeks pregnant, 12-week pregnant, 25, whatever it was, in addition to getting their bracelet, now they can actually get through this grant funded program, a navigator who's with them, make sure they have follow-up, and they can get a blood pressure device if they don't have one already at home. And we partnered with March of Dimes as well, Healthy Start Again, and some other community partners. So now they don't even have to go home without it where they connect. They can get it right when they come in, wherever they are in the building. And that probably is, from our position, it empowered women to say, wow, and it built trust. They really trust us. And we're looking at our outcomes. Certainly our SMMs, our severe maternal morbidity, has gone down. And we're looking now at the ethnicity level because the first year just completed last year, but we also now are partnering with a new partner, Florida Department of Health. They said, hey, this is such a great program. Here's another $500,000 to do that. So one of our learnings is there are resources if you're doing the work and you're willing to share your work. We've gone on lots of platforms like these, but you also have to be committed. So we found one thing and we didn't stop there. We continued it, and we've really now built what I'm really proud of for our group under Dr. Bennett, our chief of MFM, and so many others, an obstetrical medical home, patient-centered medical home. We started it in the medical side. We now have it in sickle cell, and we now have it for obstetrical patients so they can get what someone called wraparound services, everything that they need, everything we can think of. And we try to do that in one-stop shopping. But if we can't do it in one stop, they have a navigator that helps them through that process. So I think those are some of the outcomes and learnings that we're really, really proud of.
So the group is responding in the chat, and there's the wow factor here, because it's such a great example. And thanks for the show and tell with the bracelet of how you pilot something, you assess it, see if it's working, and then how might you spread and scale that. And so thanks for sharing that example, and you as well, Dr. Johnson, with the group, because I think people are looking for, again, creative solutions, innovative solutions to transform this space. Dr. Gregory, can you round us out with a great story here? Storytelling is so powerful.
Well, I'll start by saying, ooh, I'm gonna borrow that bracelet idea. Informing the other practices, the family practice, the internist, the ED, that is really important, because sometimes these women don't come back to the OB. And so I love that idea. I think that an example that I'll use is it also leverages the hypertension, but a little differently, in that there's we think that we may have a mechanism to prevent preeclampsia or decrease the incidence of preeclampsia, and that's low dose aspirin. And yet the community is not as willing to go on it. And so we partnered with community partners as well as the March of Dimes, where the other thing is, if they did go on it, they'd go to the pharmacy to get it, and the pharmacist wouldn't give it to them because they're pregnant. So we partnered with the March of Dimes and other community partners to inform pharmacists that it's okay, to inform patients that it's okay. And then when we looked at our data, we found that we weren't using it as much as we should based on the risk factors, and that there was a disparity in use, in that Black women got it least likely. So after doing an education, because there's like all these different risk factors, we actually ended up using machine learning and AI, and we built it into our EMR so that doctors were prompted that, hey, this patient's a candidate for aspirin. And we were able to go from like 25% usage with a twofold disparity to almost an 80% usage and no difference by race ethnicity. So
Wow.
that's an example.
And you're leaning into the power again here of data, right? And how do you take those findings to inform your decision making, your actions? How do you prioritize your actions based on the data and essentially use data to drive improvements in outcomes, right? And that's really what we talk about a lot in our work, our health equity work here at the AHA, is the real starting point in any hospital's journey is to get intimate with your data, do that self-interrogation. You're likely going to uncover truths about yourself that you didn't know until you peel back the layers of that onion. And so it's really important to understand your organizational story from a data perspective, and then use those findings to inform your next steps. So as you're giving advice to your colleagues here on today's webinar, what would you say to folks who want to get started, who are not as seasoned, not as advanced, they're in a more embryonic stage of development, if we want to talk in OB terms here? What do you want to suggest? How do you set up effective? What's some best practices for effectively partnering with community organizations? And it would be helpful if we could hear about it through maybe your geographies as well. So I'm interested in particular in the rural lens, right? For rural hospitals and rural communities, what does that experience look like? If we can start there. Dr. Anderson Rhodes, I think you're closest to
Sure.
rural, right? Yeah.
Sure, I'll share. I don't know.
No, not Florida. Dr.
have-
Johnson, you
we
have
have
more of a.
Yeah, we have some rural areas, so to speak, that do feed into our system. So I don't mind tackling it. I think
Okay.
one of the things that I think is really important is, number one, to recognize that you need partners, right? So we talked about that humility to recognize that there is a need. You can't do it all by yourself, or at least you can't do it well by yourself. Let's put it that way. You'll fall short of meeting the patient's needs because you're not utilizing some of those partners. So I think that's number one. I think number two is really engaging our team to work alongside of and with all of the programs in our area. We went one day and we just started Googling, finding out what's here, where are we at. So we have 6 hospitals, 3 of whom provide maternity care, but all of whom have emergency departments, and patients show up anywhere. So who's in and around each hospital area, and what's their catchment area that we can then partner with those people. So for instance, our Mothers in Recovery and Addictions program, there was already a program in our area that we knew little about. We sent an expert who was interested in that from our side to find out more about them and really decide at the baby steps, how can we partner just by letting people know about each other, and then really inserting ourselves into those programs. So I'm fully vested in our Broward Healthy Start with the FEMA program, looking at fetal and infant mortality, which actually then gives us some clues about more maternal side, right? Because it's usually a direct correlation in most instances. So that was one of the things that we said, hey, and then we found out, well, these are all the great things that they do and can offer, that we know there's a maternal health crisis in terms of mental health. Well, we don't have enough space to accommodate all of them. So who are our partners that are doing it and doing it well, and before there is even a crisis? And so asking those questions, engaging with those partners when you find out who they are, learn about them, because maybe everything is not aligned, but then spending time with them, getting on those boards. We have team members who are on the March of Dimes in every area and component of March of Dimes. They're mission critical and impacts things, and others in fundraising, etc. But also make it convenient for our patients and families with the partners. So I talked a bit about faith-based organizations. They have a laundry list. In Broward County, it's 211. I think that we utilize that. We can really co-design the best programs because they have the research. We don't have to start from scratch. And I think that's an important lesson that we've learned, is we don't have to start from scratch and reinvent the wheel. but we may need to adopt or mend to certain things, but we have to be open to what those lessons are learning or have already been learned in the community and utilize them as one of our, if not our best resources, and then partner together to make it happen.
So I'm hearing you say, first, understand your broader environment within which you're operating, just who's there.
Yes.
There might be some non-traditional partners you want to reach out to. I'm also hearing you say the hospital doesn't need to be in the driver's seat for everything. Right?
Correct.
We can share power, and we should. And
Yes.
so there are some opportunities to actually show up and embed ourselves in what the community is already doing, just as a member of
As
the
an example.
community.
One beautiful
Okay.
example of that would be with doulas. Joy, is we were, not that we weren't utilizing doulas, we permitted them, they could come in with patients, but now that we understand the work of those programs that have doulas and are promoting the community, now we can advocate for it. We can ask our patient, hey, do you have a doula? And we can go back to some of the payers and say, hey, you said you'd pay for this. Are you paying for this patient? Or if you're not paying for it, we can be advocates, in some of our spaces, those who can leverage that to say, why are you not paying for doulas?
Right.
And so that's how the partnership can then evolve. We would not have gone and done that day one, but that's where we are today working with our partners.
So I'm going to let you in on another secret. After giving birth at Cedars, Dr. Gregory, I went and became certified as a doula. So as a birth doula. And so I actually am getting ready to re-up my certification because I haven't been practicing here in the DMV. And I just I just paid to start a course in June to re-up my doula certification. So definitely, we're speaking to the converted about the power of doulas here to drive better health outcomes for our moms and birthing people. Dr. Johnson, did you want to weigh in and maybe add a little bit of that rural perspective?
Of course.
Thanks.
So how I want to weigh in on this question in regards to advice we can give hospitals and healthcare systems is to know what your hospital or your health system values. So Summa Health has values and they have commitments that they put out. So I just want to share those with you. So our commitments are to personalize care, to value every person, to take ownership, to serve with passion, to partner with the community. And so that partnering with the community looks like special programming, recognizing that we need unique partnerships with community agencies. And the last one was work collaboratively. And so although those things sound wonderful on paper and they're posted in different departments across our system, I feel like our senior leadership really holds us accountable to make that come to fruition. And so I think that that's my first bit of advice for someone is to make sure you know what your health system values and what their commitments are. And if there aren't any, to start developing that so that you will be empowered in your work. And I hear claps, so that got
Brilliant.
So,
Well said.
yeah,
Yep.
that would be my advice.
Awesome. Thank you. So we're going to hold each other accountable within the health system. Dr. Gregory, what's your advice?
I guess, as a smaller health system, I think that a relatively large academic community medical center, I think that where California is certainly going is trying to encourage the level of care certification for obstetric hospitals. And, if you go to a NICU, you're at a level 1, 2, 3, 4, but just because it's a level 4 NICU may not necessarily mean that it's a level 4 obstetric hospital. And by that meaning that it has all the services that would be needed for a high-risk mom. And so part of what we're doing is to sort of partner with rural hospitals or hospitals that are further out and provide either remote consults or, ability to transfer to a higher level of care. That's not necessarily CBO based, but it is a system level solution. And then I think the other thing Dr. Anderson Rhodes said it the best, and that is listen and listen well. Because, what we may find, in fact, we have found is that the the women don't want to come because they want to stay and be close to their families. And so how can we help meet hospitals where they are so that the patients can still get good care
That's
in
right.
a
In
local
their
resource
community,
in their
right?
community.
So you're actually building the capacity of the providers in those areas to deliver the care that the patients need. So I think we probably have maybe just 5 minutes or so, and I wanted to, in our work, we talk about the sustainability of all of these efforts, right? And at the end of the day, we think our point of view here at the AHA and in the Institute for Diversity and Health Equity in particular is that the, the sustainability agenda rests in the policy space, whether it's federal policy, state policy, organizational policy that then drives the practice within a hospital or a health system, because then that hopefully transcends any particular administration or CEO, right? And so when you think about policy solutions that might be necessary to both empower Black women to show up and demand the care, the respect, have providers listen to them in a way that impacts their outcomes positively. When you think about facilitating effective clinic community partnerships, all again in service of and to improve maternal health outcomes, what are some policy solutions that you are hoping to see emerge? Or maybe in some spaces, like in California, Dr. Gregory, you tend to be ahead of the curve out there. So I think I'll start with you, and maybe you can help our audience think about, again, that longer term. How do you sustain this work?
I think I think the bottom line, policy is a euphemism for money, right? How do we get money so that we can do some of these things? Or, is it by legislative mandate? And I don't, well, that's a whole nother discussion of how much legislation you want in medicine. But I think that the policies that I would like to see is, AKA money directed towards women being able to actually choose their provider, right? Because who you choose is who you trust. And sometimes because of your plan, you may not have that choice, right? I think the other thing is we are talking about doulas and how useful they can be. And yes, California is ahead of the curve in that we're now paying for them, but there's not enough of them. So we need to train them. And then I think that the recent extension of Medicaid for 1 year is fabulous because now we can take care of some of these chronic diseases, but we need the resources to refer the women to get these extra follow-up treatment. And then we need healthcare providers who will take that insurance, because the bottom line is half of births are paid for by Medicaid.
That's right.
And I'm not going to tell you that half the doctors take that insurance. And then I think the last policy that I think that would be beneficial is, extended paid family leave. That there's a healthcare benefit there that would improve the health of the mom and the well-being of the child. So those are just things to think about.
Awesome. Some of which have been in the mix for a while, and we hopefully we can get some traction around them to get them over the finish line. Dr. Johnson, policy solutions.
So many come to mind. So when I heard the question, I thought about money being allocated more towards housing, transportation, nutrition. But I absolutely agree with Dr. Kim in regards to funding doulas and making sure that we are empowering mothers who do not feel empowered enough yet to advocate for themselves, that they would have somebody there that can advocate for them. Additionally, we use community health workers. So I think more funding and competitive wages for community health workers who really stand in the gap for providers. So we do as much as we can, but they really provide those wraparound services, those transportation needs, moms who are homeless, making sure we're getting them housing. And so I definitely think dollars need advocated to them.
So clearly you're leaning into the workforce challenges here. And so how might we provide an expanded or develop and build out an expanded workforce using other skill sets that are complementary to the care that our birthing people need? Can you round us out, Dr. Anderson Rhodes, so I can hand off to Aisha?
Sure, sure. Most of the things that I had that came to my mind have been said, but I do want to highlight money and funding is critical. And I agree, we can't get around that. The thing that I would say about the money and the funding is really to think of it in terms of holistic care. So in obstetrics, a lot of things are compartmentalized to when you're pregnant and you're in labor or this part or that part. It has to be holistic and it has to be the continuum. It really has to start with preconceptual or intra pregnancy care, because if I had a bad outcome last time, who's let me know and what are the things I need to do to get prepared if I intend to try to have another baby. And so in a lot of the work that we're doing through the FEMA program is actually looking at those things. And did somebody get the proper counseling before they ever got pregnant? And did we set them up for success? Because their health is only in the pregnancy is only going to be as good as a starting line as where they were before they got pregnant. And so really looking at some of those social determinants of health critically and saying, if I already have food insecurity and housing insecurity and these things before I get pregnant, are those going to get better or worse once I'm pregnant? They're not going to get better. So how we address that and put those resources then for where it needs to be for an entire life cycle really of a woman, I think are important. And the elephant in the room that I would just point out and call out is a women's reproductive rights and choices. And that's not just around abortion. That's around where I go, as you heard, where I go for my care, who's providing my care, what type of care. Am I getting care in a group-centered environment, which we've known to be beneficial and actually empowers patients to speak up? Or is that not even offered where I am and I have to go and wait for somebody when it's convenient for them? Can I get that care after hours because I've got to work or I have children? So going in during a daytime hour when you won't let me bring my kids, maybe, and all of those things, which doesn't make sense. And so those types of reproductive rights and choices in the larger scheme of things need to absolutely be addressed when we talk about sustainability, because we can have some onesie twosie things, but we have to think about it holistically. And the last thing I would say, it's not just doulas. We have to think about education of our certified nurse midwives and nurse practitioners. Here in South Florida, one of our largest schools of nurse midwifery closed at the University of Miami. And so people are struggling, like where to go to get that training. And if we don't address that, we're also going to have, the maternal deserts become more desert. So I would say those would be my top three.
I mean, these are huge issues to tackle in front of us. The workforce challenge, training, finding the new workforce, first of all, to train, the non-medical needs, right? Thinking about how those show up in the clinical setting and how to ensure that women are being given the voice, they're being given access to the kind of care, the type of services that they think is best for them and their families. So I want to thank you all, Dr. Gregory, Dr. Anderson Rhodes, and Dr. Johnson, for sharing your insights, your knowledge, your lived on the ground experiences, working day in, day out with birthing people. You all are leading some meaningful and really impactful initiatives in partnership with your communities to serve the needs of Black birthing people. And I just want to thank you for all you're doing to advance health.